Hello and welcome to UH Portage Medical Center's first ever online childbirth education class, coming to you hopefully in your home as you guys are staying safe from exposure to coronavirus. So it's very nice to meet you. I wish we could meet you in person. My name is Laura Church. You'll also be hearing from Kaylee Mares. We are both nurses here at UH Portage in the Birth Center, and we're certified childbirth educators. Part of the reason that we want to come to you today, despite the disruption out there in the world, is that we know that there is a lot of uncertainty and tension related to what's going on with the coronavirus. And we also know that you have your own personal fears and nervousness associated with expecting your most likely first baby if you're here with us for this class. So one of the reasons that we want to educate you is so that we can break what's known as the fear, tension, pain cycle. And the fear, tension, pain cycle is something we've all experienced where it actually has been proven that you experience and feel more pain the more tense you are, the more tension you hold in your muscles, the worse your fears are. So by educating yourself as much as possible beforehand, we hope to help break that fear, tension, pain cycle. Here at UH Portage, our template that we follow for our childbirth education classes is called 6 Steps to a Safer Birth, Healthy Birth Your Way. And that's put out by the Lamaze Company. Those steps are illustrated for you on this slide. And your first step, step 1, is let labor begin on its own. So what are some of the signs of being in labor? The first thing you're going to notice is that your contractions occur more regularly. You might have been feeling Braxton Hicks contractions towards the end of your pregnancy. Those feel more like a period cramp. The contractions of labor are going to be stronger. A lot of times women say that the pain wraps around from the back to the belly, maybe even shooting down your legs a little bit. And unlike Braxton Hicks contractions, the pain that you experience with labor doesn't go away with movement. So if you get up and you walk around and you notice that your contractions are not quite so unbearable, that's probably a sign of being in early labor. And then the hallmark of really being considered in labor is that your cervix starts to open. So how do you know if you are really in labor? One of the ways that we tell you to kind of monitor this at home is by following the 5-1-1 rule. And it's pretty simple. 5 minutes. So that's a 5-minute interval between contractions. You count contractions from the beginning of one contraction to the beginning of the next contraction. And these contractions should be lasting about a minute in duration. Anything much shorter than that might be a sign of you just still being in early labor. And we want to know if they have been lasting for about an hour. So 5 minutes apart, lasting about a minute apiece, times an hour. That's usually a good rule of thumb to contact your doctor or your midwife. Now, there are a lot of great apps out there. We're not going to recommend anything specific other than to say stay away from apps that give medical advice, that say things like, if this happens, call your doctor. We really don't look to apps for medical advice. What we liked about this one that we put a little capture of on the screen on this slide here, it's called the Contractions app. It's available on iOS. What we liked about this is it's very simple. It's easy to use. You tap a button when your contraction starts. You tap again when it stops. There's some various little noises and visual focal points for you to kind of look at if you so choose. And it just kind of gives you a nice tracking device in order to kind of say, hey, you know, they're coming more quickly now, or hey, you know what, I thought they were happening quickly, but now that I look at the readout from the app, there may be actually only 8 or 9 minutes apart. So that's something to consider for your use. So when do you want to come to the hospital? Honestly, if your contractions are 5 minutes apart, that is a good rule of thumb. And if your water breaks, that's a do not pass go, do not collect $200 kind of moment. If your water is broken or if you're worried that maybe it has started to leak, call your provider. They're going to have you come in and get checked out with us. So there are a couple of warning signs that we do want to talk about in terms of what you might experience during your pregnancy, especially towards the end. And we don't put these up here to sort of scare you. We just want you to be aware that these are reasons why you might want to call your provider and don't delay coming to the hospital. Just come in. Heavy vaginal bleeding. We're not talking about spotting here. We're talking about bright red, like a period, soaking a pad, running down your leg kind of bleeding. Abdominal pain. Now, this is different from contraction pain. Abdominal pain is like a sharp stabbing pain. A fever, headache that doesn't go away with Tylenol, or if you feel like your baby is not moving normal for him or herself, that is a great reason to call your midwife, call your doctor right away. They're going to have you come in and get checked out. I would much rather have you come in. Any of the nurses, any of the staff at Portage would much rather have you come in and have it be a false alarm than have you sort of ride it out at home because you're unsure. Just call your doctor and come in. So I like this slide because it gives a really nice, really simple depiction of a pregnant woman's anatomy. And what I like about it here is that it shows your baby in a head down position. That's very typical. It shows the placenta up there at the top. That's a typical placement for a placenta. And you can see the baby's head. What's the baby's head resting on? It's resting on the bladder, which is why you have to pee all the time. You can see directly below the baby's head is your cervix. And, unless you're in the medical field, you might not really know what a cervix is. You might hear it talked about, but it's kind of a vague concept. Cervix is actually Latin and it means neck. So it just means it's the small little neck part of the uterus. If you picture the uterus as an upside down pear, it's the narrow part at the top of the pear. So, and you can see here that this cervix has a little path through the center of it and it's closed. The other thing that I like to point out with this slide is that you can see sort of the loops of bowel kind of sitting right behind the baby's head. And one of the biggest fears that I've encountered over the years with parents and babies is that they're worried that they're going to poop during delivery. It's a common fear for women, and I just like to say that, look, if there's anything in the lower part of your intestinal tract, it's probably going to come out as the baby comes out. There's just not a lot of room to spare down there. What I would like to tell you though is it's super, super common to have some stool come out during the descent of the baby's head or during pushing. And we want you to understand it's not a big deal. We don't care. We're not going to let you sit there in it. We'll clean you up. We'll clean you up between every contraction if we have to. And we will just be very discreet about it. Guys or whoever else might be in the room with you, don't mention it. We're not going to talk about it. It just is. And if you are aware of it and you're embarrassed by it, we're going to support you and say, no, that just means the baby's head's coming down. No, it's fine. It just means you're pushing well. If it happens, it happens. If it doesn't, it doesn't. I don't want you to stress about it though. So some of you may have had a cervical exam in the office with your provider, and they may have said you are so many centimeters dilated. We don't really in this country deal with centimeters with the metric system very often, and that's why I really like this slide. It gives you kind of a visual representation of what we're talking about. So if your doctor checks your cervix, later in your pregnancy, and she says, oh, that's great, you're 1 centimeter, and you're like, goodness gracious, what's a centimeter? It's about like a Cheerio. And you can kind of look at these common food items and sort of gain an understanding of if your doctor says you're 4 centimeters, it's about like a Ritz cracker, etc., etc. You can see 10 centimeters, we have a bagel there. Bagels vary a lot in size. Think kind of along the lines of a refrigerated or frozen bagel, not a gigantic bakery bagel. And it's that 10 centimeters that your cervix needs to open up to accommodate your baby's head, and be ready to start pushing. So that's what we're talking about when we say you are 5 centimeters dilated. It means you're about halfway open, you're about halfway there. So this slide is about the concept of effacement. And effacement is a little bit more difficult to wrap your head around than dilatation. So when your cervix dilates, it opens up. When your cervix effaces, that means it's thinning out. It's going from being a thick structure to being a thinner structure. And on this slide, you can see 4 pictures, and each one of them shows a slightly thinner, so it's effacing, and slightly more open, so it's dilating, picture of a baby descending towards the birth canal. It's very, very easy to just focus on that first number, that dilation number. And I'll have women who say, oh, I'm still only 1 or 2 centimeters. But the doctor will have said, oh, but you know what? You're 80 or 90% effaced. And for me as a labor nurse, I actually get more excited about the second number. That thinning has to happen in order for the baby's head to really kind of come down and get you ready to have your baby. So one of the best descriptions that I've ever heard about effacement involves, everybody knows Lifesaver candies. So picture a stack of 4 Lifesaver candies, and think about the thickness of that. That's about the thickness of your cervix before it starts to thin out, before it starts to efface. And each time you take away a Lifesaver candy, you kind of thin it out. So if you take away 1 Lifesaver candy and you have a stack of 3, that's approximately what it would feel like to have a 25%, effaced cervix. If you have a stack of 2 Lifesaver candies, it's about 50% effaced. If you have a stack of just 1 Lifesaver candy left over, that's about 75% effaced. So very little tissue left there. And if we say that you're 100% effaced, that means that you are paper thin. We can barely feel your cervix. Your cervix is kind of stretched out and moved out of the way, and your baby's head is really presenting itself nicely. So this last slide showing kind of the baby's head descending is showing station. And station is a little bit difficult also to kind of wrap your head around, which is why we have this demarcated pelvis bone here, showing you kind of what station means. So we talked about dilatation, that's your cervix opening up. We talked about effacement, that is your cervix thinning out. Station refers to how low in the pelvis your baby's head has descended. So you can see this baby's probably -3, barely even in the pelvis at that point. And you can see you kind of move from a negative number to 0 to more of a positive number as the baby's head moves down. If you are +3, you are going to feel it, and that baby's going to be crowning. So if your doctor comes in and says, oh, let me check you. Okay, you're 3 centimeters, you're 50% effaced, and you're -2. That means, okay, you dilated to 3, you're 50% effaced, so you're halfway thinned out, and you're -2 station. And -2 station, the head is still pretty high. But let's say your doctor checks you and says, oh, you're 8 centimeters, you're 100%, and you are +1. That's a very, very nice exam. 8 centimeters means you're almost fully opened up. 100% means you're fully thinned out. And +1 means the baby's head has really, really descended into the pelvis, is in a good position to complete your labor.
Hi everyone, this is Kaylee, and I'm going to take over as we discuss the importance of walking, moving, and changing positions throughout labor. So your baby has a big task in kind of finding the path of least resistance, where he or she has to find kind of that perfect way for their head to fit through the birth canal easiest. And mom can really assist baby in doing that by frequently changing her positions. We do recommend position changes every 20 to 30 minutes, kind of just helping baby find those perfect points that he or she needs. Also, with that, gravity is your best friend in labor. So, the more mom is upright, the more baby's head is going to push against the cervix through the contractions, putting more pressure on the cervix and helping it dilate better. So, we'll definitely be encouraging you to walk the halls and sit on the birthing ball, which really helps to open up the pelvis too, along with using gravity. And then, even once you're in bed, there are a lot of different positions that we'll be encouraging you to try. To help you find, a position that's not only comfortable for you, but also helps baby with the, descent through the birth canal. So this graphic shows a lot of the different positions that we tend to use throughout labor, and these are things that you can use when you're having contractions at home too before you even come to the hospital. Things like, walking around, standing, doing lunges against a chair can be really great for opening up the pelvis. And then also the kneeling positions, like being on all fours, leaning over a chair, can be really great for getting baby in a good position. And then lots of different sitting positions, so whether that's sitting on a birthing ball. Some of you have Pilates balls at home. You're more than welcome to use those even before you come to the hospital, and then we also have them at the hospital. If you have a rocking chair, and we have some of those here as well. Lots of different sitting positions that help open up the pelvis, and then squatting is really good too. So whether you're using your partner to support your body weight, or using a chair in front of you to do squats, pretty much anything that opens up your pelvis more is really great position for laboring. These images are of women using what we call the peanut ball. So we do have these available at the hospital, and they're great positioning tools for when you're in bed. We can use them without an epidural, but especially for moms with an epidural who their movement is somewhat limited, it's really great. As you can see, their legs are spread apart, which helps to open up the pelvis. We like to call these the baby magnet because, it helps bring baby to the outside, usually a lot more rapidly than if we didn't use it. There have been no large studies done on the peanut ball yet, but some small studies did indicate that it took an hour and a half off the time that it took to get to 10 centimeters and a half hour off of pushing, and there was another study that showed that it decreases the mom's chance of a C-section by 50%. So we definitely do see a significant difference. We've had patients, where they're stalled at 6 centimeters for a while, and then we use the peanut ball, and then all of a sudden they're 10 centimeters. It's just a really great positioning tool for opening up the pelvis, so we will be encouraging you to use it. A lot of moms do find it quite comfortable. They say it feels like they put a couple pillows between their knees, which, most pregnant women sleep with pillows between their knees. So it's kind of like that. And as you can see, there's a lot of different positions we can do with them. A great form of natural pain relief is using the tub or the shower. Warm water does just really help to relax everything in your body, and the less tense you are, the less pain you're going to have. So we do encourage you to use, this at home before you come into the hospital. Say you're in early labor and it's not quite time to come in yet. This can help you relax, which just helps things to progress. And then also at the hospital, it's a great option. So long as you're low risk and don't have pain meds or an epidural or anything like that, then we will encourage you to use the tub. We are not able to do water birth at our hospital, but we do encourage you to stay in the tub as long as you need to. There's no hard stop of when you have to come out, except, when you're getting close to delivery. We do have waterproof monitors, so if you need to be on the monitor, we can continue that in the tub. We've got nice low lighting in the bathrooms. Some patients like to bring their phones in there and play something on Pandora, nice relaxing music. So whatever it is to just make a nice cozy environment for you to relax, which does really help progress labor, so we encourage it. Another great form of natural pain relief is taking big deep breaths. So the benefits of deep breathing is that it's relaxing, it reduces your stress and anxiety, gives you a sense of calm, it decreases the tension in your body, and it also gives you something to focus on that isn't the pain. So we do encourage you to, take big deep breaths, really focusing in on that breathing. There's no right way to breathe during labor. There used to be a big focus on it with Lamaze in the past, but now pretty much it's whatever feels right to you, so long as you aren't breathing too rapidly, which can cause you to feel like, you're hyperventilating. It'll cause you to be lightheaded, give you like tingly hands and feet. So if that's happening, then chances are you're breathing too rapidly. And then also holding your breath, we don't want you to do. We want you to continue to get plenty of oxygen to your tissues. So this is something that can be great for your partner to point out if they notice you, holding your breath through a contraction or breathing too rapidly. They can just, look at you and say, breathe with me. And they take those big deep breaths and you can follow them in their breathing. It's a really great way for your partner to support you. So I do want you guys to just take a minute to pause the video and just take some big deep breaths, breathing in through the nose and out through the mouth, filling your lungs up as full as you can get them, and just releasing your tension with every exhale, and just really notice how it brings that sense of calmness over your body. And that way you can kind of tap back into that during labor, especially if you plan on going naturally. This is something that's really good to practice so it's not brand new to you in labor. So go ahead and pause the video and do that exercise, and we'll see you in a couple minutes. Now we're going to go over step 3, which is having continuous labor support, and just going over some of the ways that your partner can help you through labor. So due to COVID-19, unfortunately, our labor support is limited to one person. You've probably already heard about this from the office, but basically, so it is limited to one person throughout your whole stay. They are able to stay with you 24/7. They can stay overnight and everything. We'll have a place for them to sleep in the room, whether that's a recliner or a cot, but it is limited to that one person throughout your stay. And we do ask that they stay, on the unit in your room as much as possible. We ask that they don't, come and go from the hospital very much. But a great job for them is emotional support. So your labor nurse is going to be amazing at recognizing, what most laboring women need at certain points in time, and kind of how to help calm your fears, relax you, help with pain. But nobody knows you better than the person who's kind of with you morning to night every day of your life. So they're really great at knowing what you need, what works best for you, and the best ways to calm you down and make you feel supported. So we do encourage them to kind of serve that purpose for you. And then also, before you come into the hospital, timing contractions. So once you get to the hospital, we'll be doing this job for you with our monitors, so then they won't have to do that job anymore. Once you get into more active labor, they can tap into more of the other roles, but timing contractions is great before you come into the hospital so that you don't have to do it yourself. And then comfort measures. So these are things like massaging your back, massaging your shoulders, putting a cool washcloth on your forehead, getting you sips of water or ice chips, little snacks, things like that. And then also updating family and friends. So obviously, you're very popular when you're having a baby. Everyone wants to know all the updates, and this is kind of based on your preferences. Some people like to keep it pretty private and, just let people know after the baby's here. Some people like to update their family and friends every step of the way. Oh, they just checked her. She's 5 centimeters. Her water broke. She got an epidural, things like that. Some people like to update the family and friends every step of the way. Some people just, prefer to keep it more intimate and just share the information after the fact. So whatever you guys prefer, this is a great job for them to send out, those text messages or phone calls. And now we've reached step 4, which is avoiding unnecessary interventions. And what we mean by that is not having any interventions unless they have a medical reason to be done. So along with the benefits that we might expect from an intervention, there also are risks. So things like your doctor breaking your water could help speed along your labor instead of, needing Pitocin to speed along labor. But once your water is broken, there's a risk for infection. So things like that, you want to ask your provider, what are some other options of things we could try right now? What benefits should we expect out of this, and what are the risks? So having an IV is pretty much a hard stop in labor that we do encourage you to have an IV no matter what. And sometimes we don't even end up using the IV, but it's a nice safety net because if for some reason there was an emergency, we might need that IV access quickly. So that's something that your doctor or midwife will encourage you to have no matter what. So we do place the IV when you first get to the hospital. That doesn't necessarily mean that you're going to be hooked up to IV fluids right away. Sometimes we just leave it saline locked, which means that you aren't hooked up to anything. The line is just there in case we need it. And then when we place the IV, we're going to draw your lab work off of it. So your lab work is not a separate poke. It should all be done in, one poke so long as the IV goes in on the first try. And the main things that we're going to use the IV for are if you need IV hydration through labor, if you're being induced and need Pitocin, that would go through there. If you're going to get pain medication, that would go through there. If you have an epidural, we do need to give you IV fluids. It helps with your blood pressure with an epidural. So there are many reasons why we would end up using it. But some patients, if they're going naturally and they're low risk, then we don't end up using it until after delivery, where we do encourage every patient to have Pitocin after delivery. Now, you probably recognize that it's the same medication that we use to induce patients and cause contractions. The reason why we give it after delivery is because the uterus, it helps it clamp down, kind of like having another contraction. It helps it do that more continuously to help close off the site where the placenta was attached, so it decreases your bleeding after delivery, helping to decrease the risk of a postpartum hemorrhage, which is where you bleed too much after delivery. So this is something that we do encourage every patient to get. If you have any more questions about this, or have any desire to refuse it, talk to your doctor or midwife about it ahead of time. In this image, this woman is wearing what we call an external fetal monitor. So as you can see, she has fabric straps around her abdomen that are holding the pieces in place. So the top one is the contraction monitor, and how this works is it's got a little button on the inside of it that as you have a contraction and your uterus becomes firm, it can detect that firmness of your belly against it, and the pressure on that helps to create kind of a waveform on our tracing that can tell us when your contractions are and how long they're lasting. Now with this external version, we can't tell exactly how strong your contractions are. We go based off of kind of putting our hands on your belly to feel how firm your uterus gets with the contraction, and also based off of your report of it. If you were saying that it was mild to moderate pain earlier and now it's severe pain, we can assume that you're further along in labor. And then the monitor on the bottom is what we call the fetal monitor. It's the heart rate monitor for the baby, and it works with ultrasound technology and can pick up how rapidly the baby's heart rate is tracing during labor. These images are what we call internal fetal monitors. Now, it's very unlikely that you would see either of these. These are more for if we're concerned about something during the labor, maybe it's becoming high risk. So the images on the left, the two images at the top and the bottom, are what we call the fetal scalp electrode. So this is the internal version of the heart rate monitor. So how this works is it's this wire that the doctor would place, and as you can see at the bottom, it's got a small wire coil at the tip of it, and when it's placed, the doctor does a slight rotation of it, and it helps put that little coil into the top layer of the baby's skin. Now once it comes out, there's usually not even a mark. It's a very, very small coil, but like I said, this is very unlikely to be used. This would be more of if we were having a really hard time tracing the baby on the monitor, or if there were a lot of drops in the heart rate to where we felt like we needed to watch the heart rate a little bit more accurately. So it's very unlikely that you'll see this. And then on the right side is an internal contraction monitor. So how this works is kind of like when you check the pressure on your tires, where it can tell us exactly what the pressure is inside of your uterus during the contraction. That tip at the end of the tube has like a sensor in it that can tell us exactly how strong your contractions are. So typically the only reason why we're going to use this is if for some reason your labor had stalled, but we were expecting, or your contractions seem, frequent enough, but are they strong enough? You've been stalled at 7 centimeters for 6 hours. Let's see if the contractions are strong enough and the cervix just isn't dilating, or if it's more of an issue where the contractions aren't strong enough and maybe you need some Pitocin to make them stronger. So once again, like I said, it's very unlikely that you're going to see these things, but I have had patients before that attended class and then in labor ended up needing them and said, I felt so much better about needing these things because I had seen them before. They weren't as scary. I knew what they were for. So yeah, anything like this, I mean, just because we went over in class doesn't mean you can't get any more information. If it came up in labor, feel free to, say, hey, let's hold on a second. Can you explain this to me a little bit better? And now we're going to talk about pain control options throughout labor. So if you're deciding to go naturally, then we totally support you in that. We'll have a lot of options of things you can do for natural pain relief. And then also if you're choosing pain meds or an epidural, we fully support you in that too. It's whatever you prefer throughout labor. But just like any other intervention, there are risks versus benefits with pain control options. So we'll go over that a little bit. The image on the left shows somebody receiving pain medications through their IV. So how this works is kind of like morphine, where it's going to make you feel groggy and loopy, make you feel like you drank a bottle of wine. Now this doesn't totally take the pain away. It doesn't numb the pain. It will just make it so that you don't mind the pain as much. It works really, really well for some people. For others, it doesn't work quite so well. But this is great for like early labor. Say you plan on getting an epidural eventually, but you want to make some more cervical change first before you're stuck in bed with the epidural. So this is a great option for early labor. Now, the main thing with this that we have to be careful about is not giving it to you too close to delivery. So typically if you're like 8 centimeters or beyond, we are going to say, okay, let's not give this anymore. And the reason for that is because it takes 2 hours to wear out of your system, and it also takes 2 hours to wear out of the baby's system. So just like you get sleepy from it, the baby can also get sleepy from it. And a sleepy baby at delivery doesn't want to do that nice big cry where they clean out their lungs and take some big deep breaths. So when they're born sleepy like that, sometimes we do have to kind of help them with breathing, and we'd like to avoid that. We obviously want them to do their breathing all on their own at the start. So your nurse, doctor, or midwife will guide you on when the best stopping point for this is. We'll say, I think you're getting pretty close to delivery, so let's not do this medication anymore. And then on the right is a woman positioned for an epidural. So if you are deciding to get an epidural, it will happen right in your room. You won't have to move rooms for it. Your nurse will stay with you throughout it, and what we call a CRNA will be the person who comes up to place it. They're from the anesthesia department. So this is the one time during labor that we are going to ask your support person to leave the room. The reason for that is just because it's a sterile procedure. So what we'll do is have you positioned in this slouchy posture, kind of slouching your shoulders forward, rounding your back out, and that just helps them get a little bit of space to work between your vertebrae. So they will warn you every step of the way what you're going to feel, what sensations you're going to feel when they're ready to poke you. There won't be any surprises with this. So main things that we need before you get this placed. Say you show up to the birth center and you're 6 centimeters dilated and you want your epidural right now. So usually what we have to do is, after we place your IV, send your lab work down. We have to get results first, which usually take 30 to 45 minutes to get those results. And during that wait time, we'll also be giving you IV fluids. So you do have to get IV fluids before we place it. And the reason for that is just like it relaxes everything else in the rest of your body, it does relax your blood vessels, which can cause your blood pressure to drop. So by giving you IV fluids ahead of time, it helps to prevent that from happening. So what we can expect is that you become numb from the rib cage down. You won't have any numbness in your arms or chest or anything like that. So you should be able to still wiggle your toes, bend your knees, reposition in bed, and it's going to be, just moderate numbness. It should be enough to numb 90 to 95% of the contraction pain. For some people it numbs 100%, but you might still feel what we call rectal pressure, which is the baby's head pushing down near your bottom. So for most people that's just a sensation or somewhat of a discomfort. Most people say it's not painful, but occasionally it still is painful even with the epidural. So with this, we have to ask you to not get out of bed while it's running because of the fact that, your legs won't totally work for you, so you might fall if you stood up. So you are stuck in bed after this. It usually does wear off about 2 hours after delivery. So we turn it off once, delivery's done. Usually in 2 hours, you can get up out of bed, head to the bathroom. And a lot of people wonder, like, well, how long is the epidural going to work for? So it will be on a pump of continuous medication, kind of like an IV pump, where you'll be continuously getting medication. So it's not going to wear off. It will work through delivery. Oh, and then, so there is no stopping point with this. So as long as we can safely place it and you aren't crowning, we will. I've had patients get an epidural at 10 centimeters just fine, unless it's like, hey, you can just push and get the baby out right now. If there's some time before delivery, we are willing to place it. Inducing your labor means that we have some kind of reason why we want to give you medication to deliver your baby rather than waiting for labor to spontaneously happen on its own. So, medical reasons why we would do this is if you have high blood pressure, like preeclampsia, if you have diabetes, if say your baby is growing in on ultrasound, we think your baby's 9.5 pounds and you're, 39 and a half weeks, we might say, this baby would probably fit through the birth canal this week, but next week he or she might not fit through the birth canal anymore, so let's go ahead and get the baby out sooner than later. Or if we have any concerns, maybe your baby isn't growing enough, maybe on ultrasound you're measuring a few weeks behind where before you were measuring just fine, where we'd be concerned about, is the placenta still working well. So those are reasons why we would deliver based on baby size. Say you are 41 weeks and you're a week past your due date, they'd definitely offer you an induction for what we call post dates. And also if your water has broken but labor has not begun on its own. So the longer your water is broken, the more risk there is for infection. So we don't want to leave your water broken for, several days before inducing you. If it's broken and it hasn't started within like half a day, usually they're going to encourage you to induce labor. Now, we also do offer what we call elective inductions here, meaning that, there's no medical reason, but you just want to be delivered. There's no way for us to do an elective induction before 39 weeks. It used to be back in the day, oh, I'm 36 weeks pregnant and my back hurts, and they would induce you. Now, we're finding that, changes are happening all the way up until the end of the pregnancy. And so that could be, at 40 weeks, changes are still happening, but most babies do perfectly fine at 39 weeks. But we do encourage you to wait, wait until labor happens on its own unless there's a medical reason. But if you do want an elective induction, that's something to discuss with your doctor or midwife.
So, what are some of the things that we can do to speed up labor? So this is a picture, it's actually a really lovely drawing of a Foley bulb used for purposes of induction. And if you were in class, we would pass around one of these and you would be able to handle it and see it's just a thin, flexible tube. It's made out of a rubbery type material, and on the end it has an inflatable bladder. And that bladder we fill with sterile water, and so you get this little bit of mechanical tension on the other side of your cervix. You have to be at least 1 centimeter dilated for your provider to sort of fish this little apparatus up inside there. And so what happens is we inflate it to about the size of a golf ball, and it really just kind of makes people kind of feel a little crampy, a little uncomfortable. And it will sort of mechanically open your cervix up to about 4, maybe 5 centimeters, and then fall out. And it's actually really nice. It's reversible, it's easy, it's non-chemical, and it's something that's pretty popular right now in medical use. So if your cervix is favorable for this, it may be something your provider suggests doing. And if you've seen this picture, maybe it'll be a little bit less scary. One of the things I like to point out with this picture, and you can see the little squiggly tubes, those are the tiny little blood vessels that feed your cervix. And what I want you to understand is your cervix is very vascular. It's like the inside of your mouth. It's just full of lots of little blood vessels. And because of that, when it stretches, it does tend to bleed a little bit. And so if you go in and say your doctor checks your cervix at 38 weeks and says, oh, you're 1 centimeter, you might have some spotting afterwards. It might be a little pink on the tissue. When you wipe, you may have a little bit of spotting on your pad, and that's not a cause for alarm. Bright red bleeding in quantity is a little bit of spotting. We kind of expect that. This slide shows a couple of the interventions that are out there. We don't use them a lot. We're very proud of the fact that we don't use them a lot at UH Portage, but knowledge is power, and having a quick conversation about them will hopefully make you understand the purpose and not be overly afraid of these as being conceptual things for your personal childbirth. The first slide, the first picture on the slide shows two different kinds of episiotomies. Now, an episiotomy is done with a sterile pair of scissors. Your provider would make a small cut. There's a vertical cut and there's kind of a slanted cut. And this would be done for two reasons. So obviously, what's the point of making a small cut? It's to enlarge the opening. It used to be most women would routinely get an episiotomy, and that was just kind of old practice, bad practice. We don't operate like that anymore. The two reasons why we occasionally see providers choose to make that small cut right before delivery is, number one, the baby's in distress and we need to get him or her out now. And yes, of course, you would probably be able to push the baby out and stretch your bottom out a little bit, but it would take more time than the provider thinks is prudent to allow for. The second reason would be occasionally women have a really tight perineum. That's the technical term for the skin around your bottom. And the thought is that, oh goodness, it looks like it's going to tear, and maybe tear in a jagged way. And so there are times when the provider might just make a small incision just to allow for a slightly more controlled delivery of the baby's head. We don't do it a lot. I do want to mention the repair. The surgical repair is done with dissolvable suturing. It's very different from you have surgery on your leg and you get X number of stitches. It's like one continuous running stitch, kind of like mending the hem on a pair of pants. And so people often say, "Oh, how many stitches was that?" And it's kind of like one big long stitch. The other thing that I want to make sure that you know is whether you have a tear on your own or whether your provider creates an incision, those stitches are dissolvable. They do not need to be removed. The second picture shows forceps, and forceps are something that used to be, again, very, very popular back in the day. Usually, your grandparents will have stories about forceps. They are kind of these heavy-duty metal salad tongs. They look like salad tongs, and they just have sort of a paddle that would snug up on either side of the baby's head. And, we don't see them very often. A couple of our providers are actually quite skilled at using forceps if we need them. If, a mom is exhausted and she's been pushing for a very long time and the baby's just right there and she just needs a little bit of oomph to her push, she can push while the provider pulls. And, sometimes that's all that's needed to get the baby delivered. And the vacuum extraction, that's the third picture. That's also something we don't see very often. We have it if we need it. There's just a little handheld suction device that attaches to a sterile vacuum cup, goes on the back of the baby's head. And again, much like forceps, mom pushes, doctor or midwife pulls, and hopefully that gives a little bit more oomph to the push and we can get baby delivered safely. I do want to take a couple minutes and talk about cesarean birth, or C-sections as it's commonly referred to. We at UH Portage are very proud of our C-section rate for first-time non-high-risk mothers. Elsewhere in the country, the average is 1 in 4. Ours is about 1 in 5, so about 20%. And that may sound high, but nationally and worldwide, it's actually pretty modest. This picture here shows a pretty common setup in an OR. It's actually not our OR, but it's very similar. They're pretty standardized. Um, I do want to kind of show you a couple of pictures here. This is one of the things I like most about how we deliver babies in the OR. We do try to keep it as family-centered as possible. So this picture shows that we have a clear drape. We can drop the blue drape when the baby is born, and mom and dad can look up and just see the baby being born. Now, I do want to point out, because people have asked, can you see into the surgical field? And the answer to that is dad might be able to, he probably doesn't want to. Mom can't. You cannot look up and sort of see your innards at this moment. What you're going to do is you're going to sort of see your baby in like a little bit of a Lion King moment there, and sort of keep you more connected to your childbirth. You are allowed to have one person in the OR with you during your delivery. And as you can see, this is dad sitting right there next to mom, and that is typical. What would happen is we would take then the baby over to the infant warmer, get him measured and weighed and cleaned up and wrapped up, and hand him over to you guys to snuggle. And here's a picture of baby and mom doing some skin to skin in the OR. We've had some success with skin to skin across mom's chest in the OR. It can be a little challenging. Not everybody has enough sort of real estate from sort of the bra band up to kind of comfortably fit a baby across their chest. It's not always something that moms feel up to, in which case sometimes we'll have dad do it, do some skin to skin in the OR. So we have options, and be sure to speak up if this is something that you're interested in. I do just want to briefly talk about cesareans in terms of your support person being with you in the OR. If it is determined that you need a cesarean and it is planned, let's say the baby's breech, so that means butt first and you can't deliver vaginally, you're going to have a planned cesarean section. It'll be scheduled, and you will come in and you will get a spinal anesthesia, and that will be very sort of planned and routine, and you will get numb, and we will go out, and then we will bring dad or whoever your support person is after you're all set up and we're just about ready to start. If you are in a situation where you are in labor and it's just not progressing, let's say, you know, your baby's head is just not coming down and doctor suspects perhaps the baby's a bit big to fit out, and he or she says to you, gosh, you know, we really need to think about doing a cesarean section. We will most likely, and how this works for the majority of our patients is they've already got an epidural working. So you already have this epidural on board. You're already pretty comfortable, hopefully. So what would happen is you would go back to the operating room, and anesthesia staff would give you extra medication through your epidural. And that would make you numb enough for the surgery. And so they would do that. They would dose you up. We would get you set up, and then we would go and get your support person and then start the procedure. What occasionally happens is that anesthesia is unable to achieve adequate numbness with the existing epidural. Sometimes that means we have to move towards general anesthesia, which is commonly known as putting you under, putting you to sleep. In that case, and it's very rare, we do not allow a support person in the OR for the procedure. It just becomes a whole different ballgame. You'll be asleep. We will do what we need to do with baby and get baby delivered, weighed, measured, cleaned off, wrapped up, and we'll bring baby right out to the nursery or right back to your room to snuggle with dad, to do some skin to skin, and then you'll wake up with baby nearby when the time comes. So I do just want to make sure that you understand that there are certain circumstances where you won't have a support person in the OR. You won't know it, you'll be asleep, but that is good to know, just so that you have a sense of a spinal for a planned cesarean, a dosed up epidural for an unplanned cesarean, or potentially general anesthesia if we just need to get you comfortable. And since we were just talking about cesareans and things maybe not going according to plan, I do want to talk a minute about birth plans. And if you are a midwife patient, this will be something you'll definitely have discussed with your midwife at some point during your pregnancy. And so I like this slide because it says the power of the birth plan isn't the actual plan. It's the process of becoming educated about all of the available options. And that really is kind of the crux of the matter. I've seen women very, very rigid thinking. I want this, I don't want this. And when things sometimes don't go according to plan, it can be a really emotional, really frustrating experience. And if we were in class, we would play an activity right now called Go with the Flow, where we just kind of have conversations around, okay, if this is what you want and it doesn't happen like that, do you still get a beautiful baby in the end? Maybe you didn't want pain medication, but you caved and you got it. You still get a beautiful baby. Maybe you didn't want a cesarean and you ended up having one. You still go home with a beautiful baby. So just really think about the birth plan as a means of educating yourself and not something that you are going to rigidly cling to. There's actually some data that suggests that women who are, married to their birth plan, and things don't go their way, there's higher rates of just postpartum dissatisfaction and depression afterwards, and nobody wants that. So kind of plan to be flexible to the best of your abilities. Ask lots of questions and make sure that you understand what's going on. And yeah, just my advice is to do your best to go with the flow.
Now we're moving on to step 5, which is listening to your body's urge to push. So, how I mentioned that rectal pressure earlier, that's a great sign that we're getting close to being ready to push. Maybe you're getting a lot closer to being 10 centimeters, the head's a lot lower in your birth canal. And usually by 10 centimeters, when you're ready to push, you're going to feel a lot of pressure. And also maybe your body having what we call the urge to push, which is where it actually kind of starts pushing on its own and you feel like you want to add to it, but you feel like your body's pushing and you can't even help it. So sometimes this is numbed by an epidural where you don't get as much of an urge, but we really go off of, if your rectal pressure gets really intense, we would go based off of that. So say you're 10 centimeters dilated and you have an epidural and you aren't feeling any kind of pressure, you aren't feeling anything, that's when we would encourage you to do what we call labor down, which means that you're 10 centimeters, but maybe it's another half hour or so before you even start pushing. And while this is happening, even though you're 10 centimeters dilated, your uterus is still doing work to bring the baby further down in the birth canal. So sometimes if we wait that hour, when we check you again, then the head's a lot lower, and then maybe you start to feel some pressure and feel like you could push. So if you don't have that urge to push, then it's really hard to figure out how to push. But if it's already there, then your body's kind of telling you how to do it, and then you can just add to it. Here are some common pushing positions. So top left, you see a woman in what we call hands and knees position, where she's kind of hanging over the back of the bed using gravity to help bring the baby down. On the bottom left, you see a woman in what we call side lying position. This is really great for opening up the back of the pelvis, kind of giving it room to expand the way it needs to, since it's not pushing into the bed. It's got more room for the tailbone to move out of the way as the head comes down. In the middle, we have a squat bar attached to the bed. We actually have these at the birth center to use. They attach to all of our beds, and they're a great option even for moms who have epidurals. Most of them can support their weight in a squat position. And then, the last one is just a standard, on your back, holding your knees back. So typically you're going to see a wide combination of these things if you push for a long time. If you're someone who pushes quickly, you aren't going to see many of these positions. But typically we're switching pushing positions at least every 20 minutes. So if you're a first-time mom, on average, you're going to push for an hour. That's usual. Overall, we see first-time moms push for anywhere between 10 minutes and at very most, usually 4 hours, but that is very uncommon. Usually you're going to be done in 2 hours or less. But it's still something, being sure to get rest during labor, working up to that point, because 2 hours of hard work is a really long time to be exerting yourself. So you definitely want to focus on getting some rest throughout labor so that you're ready for this, hardest part of labor right before you're ready to meet your baby. So, if you've had a baby before, then of course this part's a little bit faster usually, since a baby's paved the way before. So usually, second or third time moms are going to push anywhere between, one push and maybe an hour at most. It's very rare for them to push longer than that. Alright, after all that amazing pushing, it's finally the part that you've been waiting for. So, delivery of your baby, when you get to meet him or her for the first time. So, something that usually surprises people about, the pushing part up until delivery is sometimes the doctor or midwife might not be in the room during you pushing if they have something else going on the floor. A lot of the times you're just with your nurse and maybe some other helping hands as we help you push, and we just call the doctor in once you're crowning, once we're ready for delivery. So at delivery, you are going to see a few extra people in the room as well. So you'll see, a scrub tech who's just kind of the doctor's assistant through delivery, and then a baby nurse, so just an extra nurse who's going to come in, whose responsibility is making sure that the baby's transitioning to the outside world well. And then if you have any other risk factors where we think that, hey, maybe baby will need a little bit of help at delivery, then we will have an extra nurse and also a respiratory therapist available, just in case. So typically, within 10 to 20 minutes after delivery, all of these people are clearing out of the room, and then it's just you and your nurse again. But there can be a decently full room during delivery. So, baby comes out, and what we're going to do is lay baby right on mom's abdomen, kind of clean them off with some dry blankets, dry them off so that they don't get cold. Just kind of assess their breathing and see how they're doing. And our goal is to keep baby right on mom's abdomen and chest without ever having to go over to the warmer until, once baby's all done breastfeeding and everything. So what happens with the baby after birth? A lot of things are going to happen in the first 2 hours after delivery, in what we call the immediate recovery period, where your nurse is going to be one-on-one with you for 2 hours, just making sure that you and baby are transitioning well into the world, making sure that, feeding is going well, things like that. So first thing we're going to do is place the baby skin to skin on mom's chest. And we will then encourage you to cut the umbilical cord. So typically your support person is going to do this if they have a reason why they don't want to do it. We do encourage mom to do it herself. Some moms think that's pretty neat. And if neither of you want to do it, then we are willing to do that for you. But it's a neat little, ceremony of cutting the umbilical cord. And then next, so at 1 minute and 5 minutes of life, we will do what we call the APGAR score, which is like baby's first test, just seeing how they're doing transitioning to the outside world, making sure that they're oxygenating well, their heart rate's staying up, that they're nice and alert, things like that. And then also we will put identification bands and security bands on baby. So baby will get a pink or blue band on their wrist and on their ankle. And then you and your support person will each get a band that matches baby's band. So it's going to have a unique number and letter set. That way, if baby has to come out to the nursery for something, when we return them to the room, we compare those numbers to confirm that it's your baby. And then also right before you go home from the hospital, we'll confirm that we're sending the right baby home with you. Never had an incident before, plan on keeping it that way. And then also they'll get a security band, which we call a hugs tag, and I always joke that it's a baby house arrest bracelet. So it does make sure that our babies stay on our unit. If for some reason a baby was taken off the unit, it would set off an overhead page and an alarm. The doors would lock down, and everyone in the hospital is trained on how to respond in that situation. Once again, we've never had an incident, and we plan on keeping it that way. And so typically, if you're planning on breastfeeding, baby's going to breastfeed within that first hour or so. And that's going to be the most important feed that baby ever does. And the reason for that is because your body is kind of like surging hormones right after delivery, where you're very receptive to the stimulation against your nipples. We're basically babies placing their food order for later on. So a good feed in the first hour or two of life, which is what we call the golden hour, has been linked to higher rates of exclusive breastfeeding 6 months down the road and higher milk supply 6 months down the road. So it is really important to use this time to get that feed in. And if for some reason, say your baby's having some trouble breathing, things like that, that we aren't necessarily expecting, but if that were happening, then we would set you up with a pump so that you don't miss out on that opportunity to stimulate your breasts. And if you are formula feeding, then of course that could happen within those first hour or two of life as well, once the baby starts to show some interest in eating. And then the baby's weight and length we're typically going to do after the baby's first feed is over. So this is something to prepare, the people at home, your friends and family waiting to hear the birth announcement, that maybe, dad will text them and say, hey, the baby's here, everything's healthy. And they're going to respond and say, how much did the baby weigh? How tall were they? So it's good to prepare them ahead of time that, hey, it might be an hour or two before we know this information. We want to give the baby a chance to transition to the world before bothering them with doing these measurements. So that way you aren't having to explain to them, 10 minutes into, bonding with your new baby, having to text them and explain why we're waiting. So it's good to just kind of prepare that so that they expect there to be a delay. And then within the first 2 hours of life, we do like to give babies medications. So the two that we recommend are an erythromycin eye ointment. And what that is it's an antibiotic eye ointment. So as baby comes down the birth canal, there is some bacteria in the birth canal. And also the baby comes out near the rectum. So those two things can cause eye infections in babies. So by giving this one-time dose of antibiotics in the eyes, it does help prevent eye infections that the baby could get during labor. And then also a vitamin K shot. So what this is it's a shot that goes in the baby's thigh, and it does help them to clot their blood to prevent brain hemorrhages. So babies are born without certain clotting factors in their blood that does put them, like I said, at risk for brain bleeds. So by giving them this medication, it does help to decrease their chance of brain bleeds for up to 6 months after birth. And if you are having a son who you plan on getting circumcised, it does help decrease the bleeding with that as well. So we do highly encourage doing skin to skin with your baby. There are so many benefits of it. So basically, baby's used to feeling your heartbeat, feeling you breathe, getting warmth from you. So it just is a very familiar environment for the baby to be, since they've been, against you all this time, and now they're in the outside world on their own, so it does help for them to be against you still. And it's not just mom that can do this. Anyone, dad or siblings can do this, where baby's just laid right against their chest. It is great for bonding. So some benefits of this is the baby does not have to work so hard to keep themselves warm, so they, in turn, it helps them burn less sugar, so that they have more sugar reserves, meaning they'll be nice and alert. They won't have any fluctuations of their blood sugar while doing skin to skin. Also, it makes it so that baby can, breastfeed sooner, which obviously is ideal. And any babies can do this. Even formula fed babies still benefit from skin to skin contact. Now we've reached the sixth and final step, which is the recommendation to keep your baby with you as much as possible. So we do recommend 24-hour rooming in, meaning that your baby's going to stay in the room with you 24/7. Studies do show that when mom keeps the baby in the room with her, she actually ends up getting just as much sleep as moms who send their babies out to the nursery. It's all about sleeping when the baby sleeps, and it's really great for getting to know the little noises that your baby makes throughout the night. Some moms say, like, oh, I wake up every little noise that the baby makes. And that's when we reassure parents that, they're going to make these little noises once you're at home too. And if they're worrying you now, at least you guys have us here to, come in the room and reassure you if it's a normal noise or not. So our nursery is reserved for sick babies, procedures, and testing. And as mentioned, there's no time that you have to be separated from your baby. You are always welcome to come out to the nursery with your baby. So something that's standard practice at our hospital that we find on a lot of people's birth plans is delayed cord clamping. And what that means is instead of cutting the umbilical cord right after the baby comes out, we give it a minute or two. So 1/3 of the baby's blood volume is still in the placenta and cord when the baby's born. So by giving it that extra time, the rest of that blood actually goes to the baby. And studies have shown that 6 months down the road, the babies are less likely to be anemic. So it does have a long-term effect. But not only that, we do notice that babies tend to be very alert at delivery and nurse better. They just seem to have more energy when they got that extra blood volume. So we do pretty much do it as standard practice on every baby. Something you might notice on your newborn is that they come out with a funny shaped head. We've had some worried dads saying, like, what's wrong with my kid? Sometimes they come out with quite a cone head, and that's just the natural way that their skull plates mold in order to fit through the birth canal. So their skull is in 5 pieces, and the pressure of the birth canal actually helps them to overlap. And then within 24 hours, the head is usually looking mostly round. It does go back to normal pretty quickly. You might notice some bruising on baby's head as well. That's pretty normal and should resolve quickly too. All right, these are examples of what the umbilical cord looks like after delivery. So on the left, you see that the day of birth, it just looks kind of like gelatinous, and it's got that yellow cord clamp on it. So over the next day, it's going to dry out, and then it's going to look like a crispy piece of bacon, like that picture in the middle. And once it's dried out, that's when we can go ahead and cut off that yellow cord clamp because we don't need it anymore. So that's going to stay on, the umbilical cord stump is going to stay on the baby usually 1 to 2 weeks, and then it's going to fall off on its own. There's not really anything you need to do to care for this except keep it dry and keep it outside of the diaper, making sure to not snag it on anything. And then you will have to do sponge baths on your baby until it falls off. Once it falls off, then you can do tub baths. Grandma will probably tell you that you need to rub it with rubbing alcohol because that's what they did back in the day, but that's actually not practiced anymore. They did find that it didn't help with the healing of the cord, but it just irritated the skin around it. So if grandma tells you you need to be rubbing it with rubbing alcohol, you just tell her that that's not what we do anymore. All right, these images show some common skin changes that we see on newborns. So on the left, you'll see that it looks like the baby has a bunch of little white heads all over his nose. So those are what we call milia. And what they are is they're just pores that haven't opened up yet. So they trap like the skin cells and the oils underneath it. And that's what causes that. They're nothing that you need to like squeeze to open them up. They're just going to kind of go away on their own as baby's pores open up. And then on the right, we have what looks like newborn rash. I know this baby looked like it was attacked by mosquitoes. I can assure you it was not. It's just common change that we see because baby's skin is really sensitive, so pretty much everything that it's exposed to kind of causes these little eruptions in the skin. They don't seem to bother baby at all, and they just kind of come and go on their own. There's no good treatment for it. One thing we do recommend is more gentle detergent. Sometimes we notice if you're using the hospital laundered stuff, that's obviously some heavy duty laundry detergent. If you then put baby in maybe some of your stuff that you washed in like a baby laundry detergent, that their skin isn't quite as irritated. So that's something to do if the baby does get newborn rash. But overall, like I said, it's mild and it goes away on its own without treatment. All right, and on the topic of infant feeding, so basically what we encourage you to do is watch the baby for feeding cues, which we'll go over in a minute. So it's not about saying, oh, the baby needs to eat every 2 to 3 hours. It's more of when the baby is acting hungry, you need to feed them. So maybe that was 45 minutes from the last feed and they're acting hungry again. That's when you want to feed them again. Or maybe they've been, nursing a lot throughout the day and now they want to take a 4-hour break. That's okay too. We just want to make sure that we're getting 8 to 12 feeds in a 24-hour period. So what you want to do is, nurse on one side, and once baby seems full or falls asleep, then you want to burp them and offer the other side. So sometimes they, only want to nurse off one side because it fills them up plenty. Sometimes they stop nursing on that side because they got all the milk out and nothing else is coming out. But if you offer them the other side, then they'll start back up because, there's more milk over there. So it's always good to offer the other side, but they don't have to eat off of both breasts each feed. And then with formula feeding, we'll kind of guide you on how much the baby should be taking. That way you aren't overfeeding the baby, but overall we're still going to follow their cues and feed them until they're full. Now, if you're formula feeding, we do like to do something called paste feeding, where instead of, because these babies can chug down a bottle really quickly, so they might finish their feed in less than 5 minutes. Well, it takes 15 minutes for our brains to detect that our stomachs are full. So if they eat really rapidly, their brain doesn't detect that they're over full, and maybe they did eat too much, and then they're spitting up for the next hour because they're a little too full. So what we recommend is kind of mimicking a breastfeeding session when feeding them a bottle, maybe taking the bottle 15 to 20 minutes for them to drink it, giving it to them little bits at a time. Give them a few sucks, take it out of their mouth, wait for them to, show hunger cues again, put it back in their mouth. So really just mimicking that to prevent your baby from overfeeding so that they don't get sick. And then back to breastfeeding. So something we commonly see is cluster feeding. This usually especially happens on night 2 after birth. Usually on day 1, what's going to happen is your baby's going to be wide awake for the first few hours after birth and nurse really, really well. And then after those first few hours, the work of, eating on their own, breathing on their own, keeping themselves warm, things like that, it's exhausting to them, and they kind of just conk out for a while, and we kind of have to encourage them to wake up to eat in those first 24 hours. But then once they reach that 24-hour mark, usually they are just wanting to nurse like crazy, and we'll just keep reminding you that it's not that you don't have enough milk, it's just a normal developmental milestone to help bring in your milk. So this is where, they're going to want to eat, once an hour, where they're, eating more than 12 feeds in a day, we tend to see. And it's not going to last forever, but it's really great to get all that stimulation while the baby's interested in nursing that much, because it's really going to help your milk supply in the long run. And then, everyone's concern with breastfeeding is, how do I know how much milk the baby's getting? Everyone is afraid that they don't have enough milk and they're going to starve their baby because they've heard horror stories. For one, we just really want you to trust your body, because increased stress can actually decrease your milk production. So trying to stay, calm and trusting your body can really help. But we do have a lot of ways to make sure baby's getting enough. So while you're at the hospital, we're going to be weighing the baby once a day, and then the baby will be weighed at every pediatrician appointment just to make sure that they're gaining weight appropriately. So what you're going to see while you're at the hospital is typically baby is going to lose weight before they start gaining weight. They can lose up to 10% of their birth weight before we're concerned. A lot of that is just fluid that's absorbed into their skin, and some of the poop that we call meconium that is in their digestive tract in the womb as they get rid of that. So we're going to weigh the baby once a day. Also, we're going to check for pees and poops. So on day 1, baby just needs 1 pee and 1 poop for us to say that, okay, baby's getting enough. Day 2, we need 2 pees, 2 poops. Day 3, we need 3 of each. And then on day 4 is typically when mom's milk is going to start coming in, usually between day 3 and 5. So that's when we're typically going to start seeing at least 6, but usually more like 8 wets a day. And, at least 3 poops, but every baby kind of poops different. Some poop with every feed, some just poop a few times a day. But you're going to be watching diapers to know that baby's getting enough. Also, just looking at overall how baby's doing. So we want to make sure that when they're awake, they're nice and alert. They aren't what we call lethargic, where they're really groggy and hard to wake up and not alert. And also that, their mouths stay moist. So just like us, when we get dehydrated and our mouths feel really chapped and dry, we want to check that on baby too. So if, baby goes to nurse and you notice that, the inside of their mouth is like sandpaper, it's so dry, that's when you'd want to call your pediatrician or alert your nurse at the birth center, because that could be a sign of something. But most babies do perfectly fine, and mom has plenty of breast milk for them. It's all about supply and demand, so just anytime your baby's willing to latch, we encourage you to latch baby on. That's really going to help. And then also not using a pacifier until the baby reaches their birth weight again, which usually takes a week or 2. So by not using a pacifier, you're not missing out on those opportunities for baby to latch onto the breast, because they could be sucking on the breast instead of on a pacifier, giving you stimulation to make more milk. And then lastly, just staying really well hydrated can help. That way your body has the fluids to put into the milk. All right, these are some of those hunger cues I mentioned a couple minutes ago. So these are what we call early cues, which is just the baby saying, "Okay, I'm hungry." So when they're kind of stirring, when they're starting to wake up out of their sleep, they're opening their mouth and turning their head side to side and seeking and rooting. It's kind of like they're just looking for something to latch onto. So this is a really great time to latch baby on because baby's nice and calm, kind of interested in nursing. So this is when you want to offer it to baby because it's gonna probably go pretty smoothly to latch them on. These are what we call mid cues, which is baby saying, "Okay, I'm getting really hungry right now. I really need to eat something." So this is when baby starts stretching, and really just kind of moving their extremities around, kicking, flailing their arms a little bit, and when they're trying to put their hand in their mouth, that's when if baby starts to show these cues, then this is like, okay, you really should feed the baby right now, or else she's going to get frustrated. And then these are those late cues. This is, baby saying, "Hey, I'm frustrated." So it's going to be really hard to latch a crying baby. So that's when we say, go ahead and calm the baby down and then feed the baby. So this is where you'd want to check their diaper, burp them, snuggle them a little bit, maybe bounce them a little bit, just talk to them, calm them down. And then as soon as they stop crying, that's when you want to latch them on. So yeah, if they're crying, agitated, and their color's turning red, you'll be amazed at what a little tomato face your baby can turn into when he or she is angry. So yeah, like I said, with this, if your baby's to this point, calm him or her first, and then try to latch them on, and both you and the baby will be a lot more calm with the breastfeeding session. All right, and for those of you who are interested in more information on breastfeeding, we do offer a breastfeeding class. It is free. It's hosted by our lactation consultant, Katie Danner. She's really wonderful. So our next classes are scheduled for May 4th and June 15th. They are at 6 p.m. As of this point, they are scheduled in person, but we can expect that probably at least the May 4th class will be switched to an online version. So if you're interested in this class, give Katie a call at 330-297-8403. She's in her office a couple days a week, so just leave her a message and she'll call you back next time she's here.
So, switching gears a little bit from labor and delivery and newborn feeding topics, we're going to talk a little bit about safety. And safe sleep is one of those topics that's never any fun to talk about, but it's important enough for us to kind of address it in this forum. And, it's one of those things that throughout the years, we've gotten a better handle, a better understanding on what is safe sleep. And so you need to be prepared for other people in your life, maybe older family members or neighbors or friends who are going to maybe suggest doing things that you might have to say, no, Grandma, that's not how we do it anymore. We don't use um, crib bumpers anymore. As cute as they might have been, they've been deemed unsafe. So let's talk about what a safe sleep environment is. So you can look at this baby laying on his back in this crib and say to yourself, wow, that's a really boring crib. But that's what we want. We want baby alone on his back in a crib. And I'm going to even expand that and say in an empty crib. So you got a firm mattress in an approved sleep situation. Now, maybe you don't have a crib. Maybe you only have a pack and play or a co-sleeper type bassinet, and that's fine as long as it has a firm mattress with a tight fitting, smooth fitted sheet. That's all you need. Let's talk about what's not in there. There's no bumpers. There's no foam wedges. There's no toys. There's no stuffed animals. There's no loose blankets. Those are items that can contribute to what we refer to in the industry as an accidental suffocation. So those soft items can get in front of baby's face and it can lead to a bad outcome. Um, A, B, C, D. The D is don't smoke. Don't smoke around your baby. Don't even wear the clothes that maybe you smoke in near the baby. That's called third-hand smoke exposure. And there's something in the chemicals that puts your baby at a higher risk for SIDS, which is that sudden infant death syndrome that we're only just now kind of starting to understand better. So A, alone. B, on her back. C, in a crib, an empty crib. D, don't smoke. Let's look what else. There's nothing on the baby's head. It's been determined that babies overheating overnight or while they're sleeping, that can be a contributing factor to crib death. Always place your baby on his or her back. There are lots of people out there who were placed on their stomach as children and they grew up just fine, and I'm probably one of them, and you might be too. But what we know now is that the rates are just lower for bad things happening when baby's placed on their back. The biggest concern parents have is, oh, well, if my baby spits up or vomits, will she choke? And the answer to that is probably not. You know, babies are pretty good at clearing. They can turn their head to the side. We recommend that that crib or that bassinet is in the same room with you in the beginning, so you're probably going to be sleeping lightly and hear any kind of fussing anyway. All right, let's talk about what the baby is wearing. Dress your baby in light sleep clothing, like a one-piece sleeper, and don't use a blanket. Um, Blankets, again, they can get sort of, even the tightest snuggy snug wrap blankets can make their way up over a baby's face and become a hazard. So there's a couple of different things. You can do the footed sleeper, you can do a wearable blanket, which is kind of like a sleeping bag with a zipper. You can do a swaddler, which has sort of snug wraps that kind of hold baby's arms snugged into his or her chest. But those are sort of approved sleep blanket alternatives. And it goes without saying, but I'm going to say it anyway, babies should not sleep in an adult bed, on a couch, in a recliner, propped up on a boppy pillow, in a car seat, in a bouncy chair, in a swing. Research really does show that bad things are more likely to happen sleeping in those environments. So car seat safety. You have to have a car seat to take your baby home from the hospital, and I cannot recommend enough getting this car seat out, unboxing it, reading the instructions, and getting it installed long before you ever have to come to the hospital, so that it's not something that's stressing you out because you delivered 2 weeks early and oh my goodness, we haven't even opened the car seat box yet. Legally, the staff at UH Portage or any hospital can't help you with the install. There's all the different kinds of car seats. Many of us understand car seats and could help you, but we really can only point out when things are not right. We really can't get into how to install it, how to adjust it. We'll help you in small ways where we can, but we really are relying on you to have an understanding of how your car seat works and what it's supposed to look like when it's properly sitting there with your sweet baby in it. So we're going to go through a couple slides and talk about, is something safe or is something unsafe with regards to car seats. And so here you got this little cutie pie and he's strapped in his infant car seat. And we're going to talk about whether this is safe or whether it's unsafe. And I'm going to go ahead and say that this does not look safe to me. And I see a couple things I don't like. Number one, those straps that go up over the shoulders, they're really loose. They're almost sort of falling off the sides of his shoulders, and we want them to be snug. We want to be able to get 2 fingers underneath there, and that's about it. Also, there should be a plastic chest clip sort of right at the nipple line that keeps those shoulder straps from falling off of the sides like they are there. So that looks like a missing piece of equipment on this car seat. Let's talk about this one, safe or unsafe. And we're going to assume that everything under that cover is properly installed, the straps and buckles and all that. And so I would say that this is considered to be a safe car seat situation. And the reason for that is, if it's winter in Ohio, we don't want you putting on a big poofy snowsuit or a big poofy jacket on your baby and then strapping them into the car seat, because what would happen in the case of an impact is that that poofy material would compress, and then all of a sudden those straps would be much looser than they should be, and there are sometimes situations where there have been babies ejected from car seats. So this sort of doesn't interfere with the inner workings of the car seat. You can run into a store, run out, to your garage, and your baby will still be safe and warm. So is this one safe or unsafe? And so one of the rules of thumb with car seats is that you never want to add something other than what I showed you on the previous slide that didn't come with the car seat. And I think we can tell from the two different materials that this pink insert didn't come with a car seat. And if it didn't come with a car seat, that means it wasn't crash tested with the car seat. And if it's not crash tested with the car seat, we can't say for sure if it's safe. And in some cases that can void your warranty if you ever have an issue with it. So, you can see above the pink there where there probably is a little bit of a head support roll. Those are very, very common. They come with all the newborn car seats. Those are fine to use. If it matches, if it came with the car seat, it's fine. If it's added aftermarket, it's considered unsafe. Okay, so what do you guys think about this one? Is it safe or is it unsafe? I would say it's unsafe. And the reason for that is that chest clip is over this baby's belly and not up across his chest. And when you think about human anatomy, we've got a lot of vital organs in that area. Do you want the impact of a car accident on the chest clip to register over soft organs or over the structure of the rib cage? And I say rib cage every time, and the car seat manufacturers would agree. They would say that this chest clip is a bit low. It needs to be over the rib cage, and that's just a matter of sliding it up. All right, this little fella, he's got multiple issues going on here. Not only is that chest clip low, but the strap is twisted, which means it's probably not quite tight enough, and that baby's wearing looks like two coats. So this would be a really good example of multiple things wrong in one picture. And we just put this one here to be funny. Obviously, nobody would ever do that, but I think this was clearly a dad being silly and messing around. And here's a great example of a safe, properly installed car seat. You can tell it's in the back seat. You can tell it's sized appropriately for this baby. That chest clip is nice and high. It's a 5-point harness. Baby's not wearing any like poofy snowsuits or anything. The straps aren't twisted. It looks good to me. So this is kind of what you're aiming for, and the insert that comes with your car seat should walk you through all of the steps in achieving a safe transportation situation for your baby.
All right, and as we wrap up our virtual childbirth ed class, Laura and I, a few months back, asked our coworkers for just a fun top 10 list of things that they wish patients knew coming into the hospital. So some of these are funny, some of them are helpful. So number 10, don't try to read the monitors. So there's a whole science behind fetal monitoring, and we do find that patients who are watching the monitors do tend to have more anxiety about it. Maybe something looks a little concerning to them. We'll let you know if we're concerned about anything, but overall we say leave that to your healthcare practitioners and just kind of focus on being in your own element and not on the computers. Number 9, bring your own pillow. So our hospital pillows are plasticky and flat. They aren't the comfiest things ever. Now that's great for labor because they might get messy, but overall after delivery we want you to be really comfortable in bed, so we recommend bringing your own pillow from home. Number 8, we already talked about this, but babies cluster feet at first, so just prepare for that. Number 7, paint your toenails and shave your legs. Now, this isn't for us at all. We don't mind hairy legs. We don't mind unpainted toenails, but if you're the type of person that you're going to dwell on this, where, whenever we're repositioning you in bed and your legs are exposed and you say, oh my gosh, I'm so sorry I didn't shave my legs, some patients get really caught up on that, and we just want you to, be comfortable and not have to stress. So if that's something that'll bother you, then just be sure to do that ahead of time. And number 6, bring your favorite snacks. So we do have room service from 7 a.m. until 6:30 p.m. every day. You are welcome to order some extra snacks with your dinner meal. We can keep them in the refrigerator for you for those 3 a.m. Breastfeeding sessions where you're feeling quite hungry. But it is hospital food, so we recommend you bring your favorite snacks if you're picky. Also, if you have any dietary restrictions, it's good to reach out to the hospital cafeteria ahead of time to make sure that they can work with your restrictions. Some patients who have strict diets, they do decide to bring their food in on their own. We can keep it in the refrigerator, and we do have a microwave you can use. All right, number 5, nobody is super interested in your mucus plug. So sometimes losing your mucus plug could be a sign of labor starting, but unless it's accompanied by your water breaking or having contractions, it doesn't necessarily mean anything. We have some patients lose it at 32 weeks and continue to go on to be, over 40 weeks pregnant. Sometimes people lose it time and time again. It can kind of regenerate itself. So it's not necessarily a reason to call the doctor. It can be a sign of labor starting if it's along with the other stuff, but otherwise don't get too excited about it. Number 4, ask any sick friends or family to stay home. Now, obviously, with the whole COVID-19 crisis, you're going to be extra cautious with your baby after delivery, really continuing that self-isolation at home, being sure to protect your baby. FaceTime and Skype are a great resource for people getting to meet the baby, and just kind of keeping your distance until all of this is over. Number 3, that labor support does continue even after delivery. So it's no fair when the mom's been up all night with the baby who just wants to be held constantly and dad gets a full night's sleep. So really just figuring out how to balance those naps, being sure mom gets some rest, especially if she's recovering from delivery. Number 2, call your doctor or midwife if you think you need to come in. So we do like having a heads up that you're going to come in. So a lot of people don't realize that our doctors and midwives are actually at home on call. They all live within a half hour of the hospital. But there are certain times that they need to get to the hospital quickly. Say they think you're going to deliver fast or you're having a complication. So it's good for them to have a heads up that you're coming in. So how you get a hold of them is any time of day, even if it's Saturday night at 3 a.m. If you call your office number that you would typically call, there's an answering service that it forwards to, and they'll page the doctor on call for you so that you can talk to them about what's going on. And sometimes they can save you a trip into the hospital, too. Say you're having contractions every 5 minutes, but they're pretty weak. They aren't super painful. They might say, okay, well, try to drink a liter of water and lay down for an hour and see if they go away. They can kind of cut out those chances of it being false labor, making sure that it's real deal labor before you actually head into the hospital so that you don't have to turn around and go home. And number 1, have a plan, but plan to remain flexible. So this relates back to when we were talking about birth plans earlier, that you just really want to, be flexible. Sometimes babies have other things in mind for how they're going to come out, and we just really want you to remember that the goal is, having your precious baby in your arms at the end of it all. All right, and that wraps up our virtual childbirth education class. We really look forward to you coming in to deliver your babies. I hope you enjoyed this class and got a lot of great information from it. If you have any questions at all, I'll wrap up the presentation with a slide that has my email address, Laura's email address, and also the phone number to the birth center. You can reach out to the nurses that are here if you have any questions. And congratulations in advance.